welcome to this week's edition of Point Blank here on Times Television. My name is Yanko Seunda. This week I'm joined by Mr. Maziko Matemba from the Health and Rights Education Program. He is the Executive Director. He's also a health activist and is here to talk about a number of health-related issues facing the health sector in the country. Do stay tuned for this program. By having different people with in-depth knowledge on different issues that we tend to tackle on this particular program, we try as much as possible to analyze those issues. Hence having Mr. Maziko Matemba today, who's a health activist, to talk about different health issues affecting the health sector in the country. For a start, welcome to the program, Mr. Matemba.
Thank you so much.
It is always an honor to have you around.
Thank you so much for having me.
54 years have gone by since Malawi attained its independence in the year 1964. How would you rate the performance of the health sector in Malawi?
Thank you so much for having me, but also for allowing me to express some of the issues which we know as an organization who are working in the health sector, more especially at policy level, but also looking at issues which affect most people in Malawi in terms of health sector. It's a good question, I think, to start with 1964, because that's when you're going to learn more on so many which has happened over time. Since 1964, as you're aware, when Malawi became independence, there are so many things which has happened as a country. And so many strategies, policies, so many government have changed. We used to have, I think, the federal government then, and then we have the one-party system, I think, after 1964, after self-rule. And then 1994, that's when we have the multi-party system of governance. So only this government, I think the health sector was not spared in terms of how we're going to manage the health system in Malawi. And there have been a lot of strategies, I mean, learning from globally. As you know, Malawi is a member of the World Health Organization under the UN system. So Malawi is not left alone in terms of decision-making, in terms of policies, because some of the policies which you have as a country, but also we relate to other countries as well, because Malawi lives in a global village. So after independence, I think there's so many things that's happened. I think we've heard that, I think, since 1964, there's one policy which Malawi government hasn't changed even today, the free healthcare system. Malawi is one of a few countries across the world where I think people go and receive treatment free of charge. They don't even charge them. Since 1964, but also other countries which I think have gained independence, I think they have changed their policies. Others are charging fees to its citizens, depending on how they have seen, they have reviewed their health system.
Having this policy in our health system, has it made a positive impact in the country?
Yes, it has made a very positive impact. But looking at the growth of the population, because since 1964, we had about 4 million people in 1964 when we were attaining independence. But now we are in the range of 18 million people. So in between, I think there have been an increase in population. And Malawi hasn't grown as a land. Malawi as a land hasn't gone up, because we have about 94,000 square kilometers. That's the land space which we have as a country. But the population has grown, even though the land remains the same. So if population is increasing, it means also the issues of health, they have to also be to change, or even to improve.
Be affected.
They're affected as well, because it means the piece of land which we have with 4 million people now, we are managing about 18 million people or more. So with those, I think that's an area which we see what has changed. And it's good that we have asked what has changed. I think the policy which was enacted, I think that they are then looking at the situation of Malawi being Malawi a country with a low-income country, with not have much income in terms of its own revenue. Because Malawi is a country with a landlocked, and also being a landlocked country, that's why you find out, I think, the certain things Malawi is still donor dependent in terms of healthcare, but also other programming. Because as you know, Malawi, the largest earner is tobacco, and tobacco is the largest earner. And of course, there have been other initiatives in terms of cotton, and other initiatives which are happening. So
basically just to expand our
expand the financial base. But I think it hasn't expanded as much as we'd expect, but the population has grown as much to 18 million. So with that in mind, I think we are still maintain the free healthcare system, which is good for people, because other countries are also trying to learn from this country. How did you manage to sustain the free healthcare? And I think also this is a lesson that I think other countries can learn from Malawi, because despite changing governments, political governments since 1964, we have had, I think, 4 if not 5 governments. I think you have seen that the policy for free care hasn't changed. So it means I think it's possible to have governments in and out, but still maintaining certain important things which Malawians mind or care much.
In as much as there is maintenance of this particular policy, it seems to me, in as much as you're saying it is so good, governments have been doing their quite some good work in maintaining the policy, you're having the problem with having this policy as well. Something keeps on telling me such.
Yes, because if you look at our health systems, that's why I go deep into a health system, we find, I think they haven't reached much. There have been improvement, and not as much. Some areas, because health care is defined by the World Health Organization by 6 pillars, right? There are 5 or 6 areas which normally you assess how the health care is managing itself. We have issues of leadership and governance. We have issues of human resource for health workforce. We have medicines and supplies. We have infrastructure and equipment, health financing, the resources, and also the actual service delivery. If we go to our facilities, I think Malawians we can also be fair to look at. I think we have managed to uplift some of facilities, but in terms of maybe to make sure that I think our health system is up to the mark, to the desired standards, where currently I think we also look at so many issues in terms of availability of medicines, availability of health workers, even availability of hospitals themselves.
Are you insinuating that the existence of the free health care system in the country is affecting all these other areas?
Not really as such, because I think, as you know, Malawi income generation in terms of this population hasn't grown as much. We still have a lot of Malawians, more than 70 to 80%, who live in rural areas, and they are informal employment. They don't gain much resources. They don't get money, in fact. Because some of the assessment we has done for the country to see how much does Malawians have in terms of their resources. I think Malawi is one of the countries which is classified by the World Bank as the least developed countries. And this is one of the least countries, I think, in terms of rating. And we haven't moved as much, because the reason why we haven't moved as much is I think the population which is underemployment, or the population who can gain employment, I think is too small. We have maybe 10% or 15% people who are in formal employment, but maybe 90% or more. I think we found out, I think that's still in not formal employment. It means in terms of for them to generate income to help themselves in terms of health care, or even to purchase health care.
It's a challenge.
It's a challenge, because if you a Malawian, you find them maybe paying for health care to the private hospitals. You find there's also struggle a lot in terms of to pay the bills, even here at my hospital or other facilities who are private owned. I think we found out the bills people are unable to commit and pay. So those things I think also have, even when you get into insurance. Most of the people who are insurance, it means dependents. It means of the 10%, most of them maybe in formal employment, they include their dependents into their insurance schemes so that they can access care. But for themselves, most of them, I think they are not on those schemes. So it just shows that I think our country, yes, it's growing. It's growing slowly, but in terms of managing, that's why maybe you have seen that governments over the time, they have encouraged issues of population. And even now the minister has got Minister of Health and Population. It's coming population because as much if you continue leaving the population the way it is, and then we'll have a problem in terms of managing the social sectors, including health. And because the demand for health care now is much more. And now you have even seen that the diseases which are coming in for the country, that diseases which previously we didn't have. We have now non-communicable diseases. These are some of the new, we call it new, they're not new, but have been there. But I think these are some of the conditions which also require a lot of resources and a lot of investment in the health care. We need, for example, currently we have heard of coming over a new cancer center. Malawi didn't have a cancer center since 1964. The reason we have cancer center, this was a part of non-communicable diseases. We used to send fewer people outside the country, to India, South Africa, and other countries to get treatment for cancer.
But the country doesn't have as much resources as it had back in the day. That's the reason why.
Yes. So if you have those non-communicable diseases coming in a country, so the country is growing in terms of social being. Because even socially, Malawi have improved. Because right here, even though we have high literacy rate in the communities, I can assure you that Malawians, they're better able now to understand certain things which affect them.
Is this you blaming each and every problem facing the health sector right now to population?
Yes, population is a factor. We can only ignore population. It's a factor. But also how we generate income for the sector, even for the government itself. How many people pay taxes, for example? We have a lot of informal sectors which are not taxed. They don't pay taxes. But we have a free care health system. We have a free education system. All these things have a burden to government, or to government to finance its own health care. That's why Malawi is dominantly, I think, donor dependent.
Mr. Matemba, you have been involved at different levels in issues to do with policy making, especially when we're talking about the health sector. Over the years, what are some of the things that you can point out that you're proud of that have made significant changes to the health sector?
That's a very good question. I think for many years I've been with the health sector. I think the previous years, I think the areas was just to learn how the health system operates in the country. Also learning as the background has given you from 1964 going through now. I think one of the key things which I think I can proudly say with my colleagues, of course, it's not a one-man job, but also maybe with other civil society and other players, was to have a discussion, not only in Malawi, but also globally at WHO, at the World Health Organization process, and even at regional, that why can't you create a space for citizens, even for civil society, to start generating information, even in media, to create that platform where I think we can proudly say we can be sit on the table. I mean, a beneficiary of services can be able to sit on the table like this one and start talking about issues of health, even though maybe they're not expert in the area. Because previous, I think, maybe you can agree with me, people who can talk about this is ably, I think, we are people who are in that profession and have stayed in that profession. But in terms of now, we are able to generate enough capacity for the population now to start demanding, but also maybe to have just a general understanding and discussion to say, why can't we have on the table? For example, I can give you the example, for example, how our health is structured now. You find out that even from the Ministry of Health itself, we have structures where community members, media, civil society, we can sit on the table with experts, with professionals, with the technocrats, and to give them the right feedback on how the system is operating. Because I think, as a medical field, as you're aware, when you're in a hospital, I'll give you that example. Most of the time I give you that example. When you're in a hospital, most of the time, the doctor wants to hear, have I given you the right medication? Have we given you the right treatment? Because it also gives that feedback to a medical professional, because they feel that a patient is also part of the process. So I think even though previously we used to have a made interaction between a patient or maybe a beneficiary of service and the one who's providing service, but I think it wasn't in such a way that, for example, you're not sick. You can be able to engage the health sector and say, okay, your such policy is not working well, or such policy is not good enough for us. Why can't you improve? Or issues of, right now we're talking issues of financing. Now we are engaging now head-on, the ministry and as partners, even beneficiary of service. And currently I can also share that even now community members, we have even encouraged the Ministry of Health through the governance structures to make sure that I think, even though some of us maybe we might be at that policy level making, but looking at where services are provided. For example, I'll give you an example at the center level. We have now health advisory committees. We have heard that most of the members at that community level have been trained on how to monitor services at that level, without maybe waiting for some few or maybe some individuals at the national level to be commenting about these issues. But in the future, in the next 3 or 5 years, we find that people now commenting issues of health as it's happening. For example, issues of budgeting. Previously, we didn't know how much goes to the health sector and how is it being utilized. But now I can able to say, okay, I know how much which goes into the sector.
The availability of this particular platform where different stakeholders will come together and discuss issues to do with health. Of what impact has this particular initiative had on the health sector?
I think the most impact is ownership. Because I normally even argue with the system that if I'm a patient, normally I would want to know. For example, if you go to a facility and maybe you're being told at the extreme to say, I don't have such type of medicine. normally you're going to ask, but you hear that budget has been given. We have money and we have medicine. So for someone to start asking those questions, it means that someone has been empowered. For able to start constructive questions and to say, for example, issues I've already mentioned, the dialogue around financing. You know, the health sector is not widely financed in terms of percentage. I think the current budget for the last 3 or 4 years, I think our health budget, as it relates to the national budget, has been at 10, 11%. Somewhere, some years back, we used to be at 15%. And if you talk about those figures in terms of trickle down to actual money which goes into actual service delivery, if you remove maybe other administrative costs, you find that the money which goes into the actual service is a bit small. But how can a patient or a beneficiary of service be able to say, okay, if the amount is small, how do you prioritize? Or how can I benefit out of the small amount of money, which I think you're able to provide as a service? As you are aware, I've told you that you have a free health services. So to have that discussion and that strength or capacity to start demanding, so no. If the money is not enough, where will the additional money going to come from? That's another debate. We have private sector in our communities, even in our villages, even in our districts. But some of them, that's another area which we are going through now. We want to engage in the private sector. I know they pay taxes. They help us in pay taxes so that we can provide social services. But I think we need to engage them. Maybe there are certain things which, I mean, private sector. For example, others in construction industry. Maybe they might have the will, maybe the interest, maybe to help us in terms of building hospitals, or maybe to support the system at that level. But if we don't engage them, they will not know. So those are some of the things I can say I can be proud of, that I think with my colleagues we have managed to open up.
Still sticking to the issue of finances, there has been talk about the Abuja Declaration, which Malawi is a signatory. The Abuja Declaration encourages countries that are party to it to commit 15% of their national budget to health. Has this happened before in this country?
Yes, it happens, I think, once. I still remember the years. It should be 2011, 2012 financial year.
In as much as there is an existence of this declaration, it only happened once in this country. What did you do to enforce it to be happening yearly?
You know, issues of health finance is dynamic. They also change with, I think, prioritization in terms of what people are saying. For example, as civil society, we have been, I think, from day one, we have been lobbying since 2000 to say, make sure that it's 15%. And there have been other conflicting priorities by different government over time. But also interest of within the public.
What is the actual response that you do get from government when you ask for it?
Government will say, yes, 15% will provide. But we have other sectors, for example, agriculture, education. They also need similar. For example, there's been this argument to say, also you need educated population for them to avoid contracting diseases,
for example. Do you refer their response to this particular declaration?
Yes, we refer to the declaration. But in terms of the 15%, because the 15% was tied towards the local domestic resources. But you know, health sector is also heavily financed by donors, partners. We have big donors, like the Global Fund, we have the Gavi, we have the USAID, the Americans, we have Norway, you have the European Union, you have the UN system under the UNFPA, UNICEF, and all those UN systems, UNAIDS. Those are also big partners who also put their resources towards in the health sector. So we have been having, I think that's some of the discussion we have been having to say, okay, with that support which comes in country, and we have the 15% Abuja, how do we make sure we correlate the two? To make sure, because at the end of the day, the most important is the resource. It doesn't matter where the source is coming from. So we have been having that discussion, and currently we are doing analysis of all those donors.
You said the last time that you had this 15% being ordered was in the year 2011?
11, 2012, yeah. I think
this is 2008. Are you failing on your job to, enforce this particular act from the government?
What has happened over time, which I think I just want to maybe to share with you, that even though I think the absolute figure might be small, but I think there has been an increase into the donor input, donor inflow to the country. And much of the donor donor organizations haven't left this country in terms of supporting the health system. And the 15% just complement. But the reason why we still push to this...
In as much as the 15% complements, it still does make a difference. Because if we're getting 10% from the government, it is quite lesser than the 15% that we're supposed to get. And considering that there is more money coming in from the donor society, with the added 5% that we are lacking, there could have been a difference that would have been made in the health sector.
In fact, if you ask me personally, I would allow our government, my government, to make sure at a minimum 15% has to be given. It doesn't matter where the money is coming from, whether donors are paying money or not. Because
but in as much as such is your wish, you're still failing to push the government to honor the deal.
We have pushed the government. And every year we pushed. I think we have seen every year in out. We have been pushed the government to do that.
But in as much as the pushing is there, it is not bearing any fruits.
But you can say that maybe it's not bearing any fruits because I'll give you the absolute response. Because we also monitor
Perhaps the approach is not good enough?
No, the approach could be, because I think the commitment which was made, I think there has also been an amendment to the commitment. Even though as much as we have the famous Abuja Declaration of 2000, the originality of the Abuja Declaration was around HIV financing. When countries made in 2000 in Nigeria, that's what's called Abuja Declaration. I think the niche was on the 15% towards HIV. Reason, if you remember very well, but in the year 2000, we didn't have institutions like the Global Fund, so people were dying. Most of the African countries. So health ministers made us say, "Hey, people are dying. Why can't we start investing into HIV?" Abuja Declaration was come originally, historically, was come by HIV. Why can't we put 15% of the money go towards HIV so that we should stop our people from dying from the disease? Then, in the same years, that's when the Global Fund was created. The Global Fund for HIV, TB, and malaria. So, the Global Fund came in as to fill the gap. So most of the countries, not only Malawi, it's not unique for Malawi. This campaign, if you even go around the country, across the region, you find out it's not unique for Malawi. You find out most of the countries, because of coming with the Global Fund, which input a lot of money into the HIV sector. You find out most of the countries, they said, no, the Global Fund is providing the money.
So we have to relax.
We have to relax. It's not that you can't relax, but they were trying to balance, to say, okay, if the Global Fund is providing this money, but of course, after some time, the African Union, because I think the Abuja Declaration is the AU initiative. So after some time, they started now reviewing. Does it make sense now when you have the Global Fund in place, which also providing money and resources to HIV, TB, and malaria? So the amendment was, okay, why can't you look at the whole health system, the whole health system in Africa, not only focusing on HIV, because at least the Global Fund has coming in. So it also created that change in approach to say, should we continue with the 15% Abuja Declaration, or the things which were being advocated? Because it was used as a campaign, as an advocacy campaign, to make sure that if you put money 15% at a minimum, then we will not see a lot of our people dying of HIV. Okay.
Yeah. Let's leave it there for now. We're going to take a short break. In case you're just tuning in, you're watching Point Blank on Times Television. My name is Yanko Seunda. Today I'm having a conversation with Mr. Maziko Matemba, who's the Executive Director of Health and Rights Education Program. We will be back after this break. Welcome back. You're still watching Point Blank on Times Television. My name is Yanko Seunda. My guest today is Mr. Maziko Matemba, who is the Executive Director for Health and Rights Education Program. Just as a reminder, the program is produced by Elvis Ahoahoa. We're discussing health issues affecting the country as we are 9 months away from the 2019 tripartite elections. That is also another issue that we ought to address later on in the program. But there are a number of challenges that have affected the health sector in Malawi. We talk of shortage of health workers leading to a high patient doctor-nurse ratio. How did this come about?
It's so sad that I think at day and age, after so many years, as you're aware, Malawi attempted even did coming up with some of the training institution for doctors and clinicians and medical personnel. We have the College of Medicine. So our interest was, once we had the College of Medicine, our interest was, I think, we'll have sorted out in terms of having professional health workforce in the country. I think the College of Medicine here trains about 60 doctors in a year. That is the minimum which they could train. And we have a health institution, that College of Nursing. We have other College of Health Sciences across in Lilongwe and Blantyre. But also we have private training institutions which also train doctors and others through the CHAM institutions. So they also train all those cadres in terms of making sure that the numbers are adequate. But the reality, because this is point blank, so we have to talk of the reality, what's happening in reality on the ground. Since even though we're having all these professionals in place, but we still have gaps. The ratios between the doctor and the patient is not adequate. And Malawi is still struggling to meet the minimum standards as shrined by the World Health Organizations, but also even including our health facilities. The challenges are many, because I think one of the things which maybe we lost sight of the fact of having a workforce in our facilities is it's not just a matter of training them, but also the other underlying issues, which also we are supposed to go hand in hand in terms of having all these training institutions. For example, if someone has finished college or have finished to be trained, when are you going to employ them? Because you need to have a plan to make sure that I think there's money available in government to start employing them.
And some of these graduates will take 2 or 3 years
to be employed.
Yeah, sure.
So normally even the government need to have money. And as you are aware, Malawi as a country, we also have a caveat under international institution that the World Bank and the IMF, normally they say, well, Malawi should not increase numbers of civil service, not more than 30% of the budget. It means our budget, we have to make sure that 30% maximum has to be the civil service, including medical doctors, including teachers, including everyone. To have that caveat, because normally that caveat comes in because of, do you have resources? Can you manage? Even though if you don't look at the wider interest or maybe demand, which is there in terms of reaching out, for example, how do you balance the patient and the doctor? Even in the school setting, we found out the ratio between even the school which
teachers and pupils.
Yeah, even the school which the primary school which I went just some months ago. I found out that one teacher is teaching about 200 pupils.
But the reason why we have organizations like yours is to make sure that when such gaps exist in a sector, you're able to provide solutions to such. What solutions have you provided thus far?
We have written and we have even offered solutions to government to consider, to have make tough decisions. Because I think it also takes to have make a very tough decisions.
What are these tough decisions that
if you, for example, you have been a caveat to say only 15%, 30% of the civil service has to go towards paying salaries for civil servants. We cannot go beyond that. Because the other 70% goes to other areas, for example, infrastructure, roads construction, all those things. So you also need to see how in the 30% we're going to prioritize. Because there's also issues of prioritization. Or do you prioritize health sector? Do you prioritize doctors? Do you prioritize teachers? Do you prioritize, for example, agricultural experts? Do you prioritize all those things? Do you prioritize the general civil service? We have civil service, like we have drivers, we have cleaners, we have so many things also happening in terms of when you're trying to increase the wage bill.
Issues of health deal with the life of a person. Life is prioritized over everything, and I believe you approaching government over issues of prioritization, they ought to have prioritized the health sector over every other sector, right? But still more there is a gap.
Yes, in fact, filling the gap is, that's why I think maybe if you go economical language, if you widen the economic base, because I think our economic base is too narrow, it's too small. And you cannot budget waiting for foreign support. That's why I think you heard recently, the ambassador for India said no any country has developed depending on donor money. And I listened to him, I said, let me hear what he's trying to say. Because donor money, even though it might look as big as you could wish, there are also different interests. As a Malawi, we have an interest. As donors, they have interest. So for you to ban that interest, you find out maybe some of the interest which goes into the general populace, I think it doesn't match. Because normally, as donors, they will come in the country because of different interests, as I already mentioned. Others maybe they're seen, others maybe those interests as how to make sure that are so well supporting other countries. So what I would wish, which we're also trying to push, because this was only unique to the health sector, it will go across all the sectors. And we have managed, for example, currently, we rob it that there's no way you can train a medical personnel without you have been employed. It doesn't make sense. We had some problems now. The Minister of Health has started now employing. And they'll be employing, we hear about 1,300 health workforce. Which
are you satisfied with that development?
Yeah, we are very happy, because I think it doesn't make sense to train them and not employ them. And also we're looking at how we can open up in terms of not only relying on public service. Because the problem is we want all the doctors, all the nurses to be employed by the public service. But even if you have a private facility, if you have a medical doctor who's trained in Malawi, it's also helping the same population. So it's an issue where also we need to think through how do we open up in terms of making sure that when we are saving, whom do we save? We have to make sure that the public service is affordable. For example, heavy service is affordable for everyone else. For example, I'll give you an example, because there are other issues which maybe we don't discuss. I'll give you an example that Malawi made a decision. If you look at taxes, the medical supplies is tax-free. The actual medicine, all the medicine which you buy in pharmacies, the reason why medicines are cheaper is not that they are cheap outside, but government made a decision that have a zero tax on medicines and pharmaceuticals. The reason was simple. Reason, we have to make sure that they're affordable. So you can find all these people, all suppliers who are buying medicines from outside the country. When they come in the country, they're not taxed for medicines. Of course, maybe there will be a tax for other things, but not for medicine itself. But those are some of the things which I think as a country we managed to push.
So many challenges.
To make sure. But you ask the question of to say, why do you have shortages? Shortages are there. Reason being that even though we are training every year and of course, another positive thing which you don't discuss, if you check most of our facilities now, we have seen a change. Because you know the medical college didn't start a long time ago, the College of Medicine. Of course, comes the College of Nurses started a way back. That's why we have many of nurses. But if you go to public, if you go to most of the public district hospitals, we find out we have a medical profession, almost 2 or 3 of them. Now, even I've heard that even when you go some of they're trying to even to deploy some into health centers. But the challenge is, that's what I'm saying, training is another thing, paying them is another thing, but these are professionals. Do we have housing for them? Do we have other facilities for them to work on? Another issues of availability of equipment in hospitals. We have a well-trained doctor, a specialist doctor, maybe specialist in cancer, for example, but you don't have a cancer center. It means it's doomed almost irrelevant because you cannot do anything because you are specialized in cancer, for example. So those are some of the things which now I think now we are pushing government to make sure that they now start investing into infrastructure and equipment. For example, this budget, if you ask me, say, what have you done? We push to say, you have seen that the Ministry of Health for the first time have started the process of now putting money for infrastructure and maintenance of hospitals. And in the budget, we are still following up on which centers. We have just heard that I think they'll be maintaining about 42 health facilities where they will have a state of art. For example, you have seen Central Hospital in Longwe, where they have state of art. I think they have improved some of the rooms where I think patients can go there with that. I think we saw it. I think it was on TV as well. So those are some of the things which I think we also to push to make sure that, hey, you can have a well-trained doctor, but these people that are well-trained, they also need an environment where they can practice what they have been taught.
In as much as there has been some sort of absolute conversation on issues affecting the health sector, some of the issues arising concerning hygiene. Hygiene is measured as another problem with toilets that don't work and at times no water in these facilities. How do you explain that?
And it's a sad situation. And as a citizen, but also someone coming from a civil society, sometimes I feel to say, what wrong did we do? You find a very new hospital, very, very new health center. go there after 6 months, you find it doesn't look new anymore. It's either toilets are broken down, the water is not running, the waters are not looking good, even the beddings, they are not as new as it was looking like. If you check some of the new state-of-art facilities which have been built by government, you find out that there are certain things which are missing. That's an area which we are trying to say what wrong is happening. Because the problem in managing facilities, it was the absolute, I think, responsibility of the Minister of Health. You're forgetting that when a patient is put there, you have patients themselves, and even guardians who come to those public facilities. You find broken windows. Even people stealing linen, which is supposed to help another patient who's supposed to come. So the issue is manifested in terms of how do we make sure that the public now is also capacitated and trained for a behavior that will make our facilities look what it's supposed to be.
So in this particular case, who are we blaming for failure to maintain the health facilities?
The first blame will be the minister itself, but another blame will be as we, as citizens, as patients. How far have we gone in terms of making sure that those facilities, when they're built, they're built for us. When I get sick, I go there and receive treatment in that facility.
How far have you gone as an organization?
What we have done, that's a very good question. Recently, with the Minister of Health, we had discussion where we have developed the community health strategy. I'm calling community health strategy is one of the landmark strategy we have been developed. Of course, there are very important strategies which the Minister have developed. But looking at the area of demand, because I'm looking at it, because we have a supply side and the demand side. So most of the patients and most of our work is on the demand side. Also, we demand service. So on the demand side, that's when you have patients, beneficiaries, we have civil society, we have all other stakeholders which support the Ministry of Health, apart from the health Ministry of Health system themselves. So the other issue which we have been discussing is we are improving through other partners. We are now training, as already mentioned earlier, the hospital advisory committees or the community set up in terms of health care. Because at the community level, we have committee members who normally we are training them and also we are encouraging them to do part and parcel of the health system in terms of if maybe someone has stolen medicine, where is it sold? It's sold in the same community. How do you make sure that the community do not allow themselves to be buying?
How effective will this initiative be?
It will be effective because I think we are putting roles and responsibility, but also commitment, because we're also involving not only the advisory committee members, but also involving the chiefs and other structures to make sure that if something goes wrong, because you are part of management, because what is happening now, previously it would be, I think there would be loose voluntarily set up. Come now, we have embedded into the structure of health. So what will be happening now is if these committees make a bad decision, for example, and one of the things which also we are training them is on financing. They'll be starting now making budgets, even at that level, to say, okay, how much do we want? How much money do we have? What gap do we have? But previously, that was not happening. And also another issue, we have had issues of coming over hospital ombudsman. Because for a long time we didn't have hospital ombudsman. We used to have them before, but I think we have had recently, I think the ombudsman, the Minister of Health launched with the minister, I think they launched the ombudsman's office in the hospitals. So that when people complain, for example, cases are complaining, where do they report to? They can report to us maybe after 2 days or so, but someone is suffering right now, we need to report to a certain structure. So that after some time we can generate that information and analyze what has happened. So those are some of the good things which internally we're also doing to push to make sure that it works.
Issues of management seems to be so much of a big deal, especially for health players in the country. Not only are we failing to manage some of the infrastructures that we are given to be used at a health facility, but we're also failing to control some of the diseases. For example, cholera. The only time that we didn't register any case of cholera in Malawi should have been in the year 2012 and 2014. But all these years, we have failed to address the problem of cholera. Where are we getting it wrong?
It's sad that I think in terms of you're trying to manage the health systems, there are certain conditions which you have to do away with it. Cholera, basically, is issues of hygiene. So it doesn't make sense to everyone else that at this day and age, we still have conditions which are treatable, preventable. But if you talk issues of cholera, it's not only around the health sector. It also goes beyond the health sector. For example, provision of potable, clean water. You find that we have your Minister of Agriculture and Water Development. We have other players. In town, we have the water boards, which are supposed to provide clean water. So, in terms of having cholera, for me, it's a thing which sometimes I ask myself, what wrong have we done? Because I think cholera...
Perhaps are you sleeping on your job?
No, because I'm saying it's much sectoral. Because for someone to provide clean water, it's no... The health sector doesn't provide water. You need to have another institution which also provides the same water, potable water.
But you said there is a room or a platform for an open conversation where all these sectors can come together and discuss some issues.
And most of the cholera cases, if you check them, they happen at the rural setting, at the rural community, where people maybe they don't have, they take water from the, from the river, they take water from other sources, which sometimes is unclean. For example, I'll give an example on how people construct their toilets. Normally here in town, even if you find someone who want to build your toilets, they will tell you, you don't build a toilet where there is a source, a toilet source, or where there is a source for water. You need to do that. So it's an issue where I'm saying it goes back to our structures. For example, the district itself, the district commissioners, the district assembly, that's their duty anyway, to make sure that, okay, for example, in terms of structure, if you are giving plots, for example, that's what I'm saying, it's wider, it's multi-sectoral. If you are giving plots to people, people are even now building their houses in the river. You see? So it's issues of town planning, which is beyond maybe the issue which I'm trying to say. So it's an issue where multi-sectoral in terms of discussing the whole thing. And now I'm happy because also another positive thing which was pushed as civil society. I think you remember 2004, the decentralization. To us, decentralization is also one of our take home, which we're going to remember for many, many years. Reason why decentralization is important is I think decision to be made at that level, at that local level, it also becomes important. Because previously, the reason why maybe we have delayed a bit in terms of development, including the health sector, decisions were made at national level. So they used to be back and forth. But currently, I think in future, in the next 4 to 5 years, if decentralization, I think, is managed comprehensively in terms of making sure that power to the districts now is given, money is given to the district, they are able to make their own decisions. I think some of these things will come to an end because now if you, for example, you want to buy land, for example, or you have to have papers from the national level, and maybe you disagree, maybe you want to build maybe a pit latrine, just because maybe the powers is not well defined. Who has got the powers to make those decisions? So I believe decentralization also, if well done and it's well supported, it's an area which I think in future we might feel that I think people will not make those decisions which can also affect their health.
With just about 2 minutes to go before we wrap up the program, I bet there are a number of issues that we need to talk about. You need to come again because there are issues to do with sexual reproductive health that we have to talk about. Issues concerning creating a barren nation that we really have to talk about. But anyways, we are 9 months away from the 2019 tripartite elections, and most of the politicians are going out, speaking out on different issues that they feel Malawians need addressed. In this particular case, you as a health practitioner, have you gone around snooping into their manifestos to see what health issues they have in their manifestos?
Yes, in 2014 we did that, and we went all the major political parties. And even the small political parties, I won't mention names here. And we were bringing issues, which normally, the feedback we have, because I think working in the health sector for almost 15 years, I have some knowledge on how the health system operates, and also getting some experience on what would be the best way.
I'm going to rush you through the explanation. That was in 2014.
Yes.
This is 2008.
What we did normally, we share this to political parties to say, consider this.
Have you done it this time?
We are yet to start now because most of
with the delay.
Yeah, because most of them haven't come up with their manifestos and even their timeline.
So you have to wait for their manifesto?
No.
To be included in their manifestos?
Basically, I think is in 2 ways. I think most especially our programming comes maybe 3 months before the election, just to check their manifestos. Because sometimes also they commit what they will deliver. Because we just share that information. This is our experience, how we feel we can improve the health system in Malawi. it's a choice to ignore, to accept.
You live health issues on an everyday basis. Do you have to wait for your program to come to pass for you to approach
For example, right now,
to include
some
such things in their manifestos?
Some have been asking, okay, what are the major game changers? To say, okay, this is a game changer. If you do this, this is what's happening. For example, another issue which I can share with you, which I feel this is also maybe an opportunity to share, that continuity of programming, more especially in the health sector, because not much is changed. But I think maybe the approach changes depending on the different government who comes in, because there are different personalities. But the most important thing is it's very important for political parties to get what the technocrats, what the people who are managing the healthcare system on daily basis. And we have civil society, we have doctors, we have clinicians, people who know every day what happens.
In as much as you would approach these political parties on these issues, you did that in 2014. We haven't seen so much of progress in terms of how health issues are tackled in this country or are actually addressed. What should make Malawians believe that this time around, even if you approach them, there's going to be a substantial change?
In fact, that's a good question. What we are doing now, we are doing analysis. Because you remember it was 2014, and we gave the political parties for 4 years to implement. Because we cannot just checking them when maybe they haven't started planning, because they need money, they need human resource, they need leadership to change the status quo. So what we are doing now is we are doing an analysis. And by November, we'll come up with an analysis on how politicians they have improved the health care in terms of what they promised. Because also you need to check what they promised and what they deliver. If they haven't delivered, we even say it. We share at this platform to say, they said what this is what going to do, and this is what they haven't done, or the other issues are progressive, or others have been done. But in terms of certain things are happening that I think some of the political parties promised to say if this is our manifesto, this is what we're going to do. So it's an issue where I think we need to unpack them. I think we will have that forum where we share with them to say, well, this is what they promised and this is what they have done, and for the future they also need to consider certain things so that we improve the status.
Unfortunately, we have run out of time, but you need to come back for this program. We need to continue with this particular conversation. But thank you very much, Mr. Maziko Matemba, for coming through. I really do appreciate it.
Thank you so much.
On that note, we have come to the end of this program of Point Blank. And my guest today was Mr. Maziko Matemba, the Executive Director of Health and Rights Education Program. The program was produced by Elvis Hoa Hoa. My name is Yanko Seonda.